first little bit, 2 minutes I'll take on peripheral venous, since all of you all know how to take a peripheral line. So peripheral line, which one you select, which is most prominent, which is most distal, so that if you fire this, then all this is also gone. So you should, and see that the hand or limb or wherever you are taking, it's resting on the some side something. Don't keep patient's hand hanging, it pains. As it is, patient is in little stress because of surgery or whatever. So don't keep the hang. Invariably, I find no, you all tell patient SRFO. So it pains them. Plus, see that it is independent. So this is there. So you should clean the area. Spirit, to say it, spirit has advantages. It disinfects, it hardens, matlab ye karta hai, and tap it. Always tap even if a good vein is there. Make a habit of tapping so that it releases histamine and dilates the vein. Okay. And important thing to remember, whenever whatever gauge of venflon you are passing, see, even if half bevel is in the lumen, blood will come. So your judgment has to be there that the full lumen is in the full bevel of the venflon or whatever is in the lumen. Then only that sheath which is there up will go inside. If half bevel is inside in the wall and half is in the lumen, still you will get blood because some part is there, but that sheath will not go. Clear? That concept has to be clear for arterial, for venous, for central line, for everything. So that judgment, you usually you give little giveaway you have, depending on the, so artery is hard, stiff, so you'll have little more giveaway. Spinal may you get giveaways, na? So you'll have little more giveaways as compared to a vein which is little softer. Okay. So we have that. Those who are not confident and want to practice that, we have kept that also. And we'll have on center. The other thing what we'll have is, I'll teach you a landmark technique. So if there is no ultrasound available, how to do that. And then we'll have the ultrasound. So Anil will also be helping in the thing. We'll have everything here. First I thought that side, but there is waste of time and there is some work going on that side. So we'll have everything. It will congested. It will. That's why I want all of you all with your mask up. Okay. So now central venous cannulation. So what I'll be teaching you with all methods. So one method, what all the sites which you all know of is, one is internal jugular ear, then you can have brachio, you can have femoral and subclavian. This subclavian and internal jugular are most common ones which we do, and peripheral inserted is the brachial one. Now amongst the internal jugular and the subclavian, anesthesiologists usually prefer internal jugular. Okay. One is internal jugular. Usually of the two sides we prefer the right side because it is straight, less lung is little lower, so pneumothorax chances are less, and even the thoracic duct is on the left side. Okay, so these are the three main reasons why we take on right side as compared to the left side. Now comparing IJV versus subclavian. Subclavian, very high chances of this thing is there. So in trauma and emergency situations where you want fast and all that, little faster it is, but chances of pneumothorax is there. So non-anesthesiologist, intensivist, or in the area of casualty or something, they will prefer taking a subclavian. Okay, and usually, and this I'm just saying the trend, both are fine. Also, if we are doing IJV and all, it's about the neck. So unless there is surgery over here, it doesn't interfere in the surgeries and all that, scrubbing and all that. It's subclavian if they are doing something. Here now, common central lines are taken in which OTs? One is where you want peripheral, peripheral access is not there, patient is going to remain NBM for long, and in cardiac theaters, an intensive. So cardiac sternotomy most of the time will be there. No? So if you have in subclavian, it's going to come in the way. Okay, so that's why most of the places we will take the internal jugular, because we are predominantly in the operation theater. Those who become intensivist and all is a different thing later on. But I'm just saying your learning of 3 years is predominant in the operation theater. So hence we have internal jugular is what we usually prefer. Okay, so we'll have internal jugular, then we'll have the different approaches which are there. I've left side, right side, I've already spoken about. Subclavian vein, I've little spoken about. Then steps. External jugular, the one which you see outside, that's the external jugular, but that has valves. It will not go right properly in the right atrium. Where you want it, you want the tip of your catheter to lie above your RA. So in the SVC, it has to be there. The site has to be in the SVC. Okay, then only you have a proper CVP. Hence, that full length of the thing should not be inserted. There are ways in which there are formula and all like that, but approximately 12-13 centimeter is approximately in adults where your tip should be there. So there are markings on the catheter every centimeter. So you should insert. Don't insert the full thing is 15 centimeter. Probably this has been designed for Western population. So it's always a waste. I always feel that length is a waste. Means I don't know why they make so long ones. I've never understood. Okay. Then femoral and all will not cover because we don't have the mannequin and it's not that commonly. It's the first year. Better you all know peripheral and your IJV. Okay, and we will teach you all our ultrasound guided. So many of you all would have not done that also. So that's okay. In your 3 years, you'll get to do everything. So ultrasound guided. So Anil will teach you a little bit basics of ultrasound. Very basics. Those who are not done in the theaters where ultrasound is there, you will have must not be aware. Very basic and how to hold the probe and how to cannulate. So if you are not able to do, don't get disheartened that I am not getting my cannulation today. So you will be able to get it, and we may have probably again also. So that time again you can come. Okay. So it provides what is the help of central venous cannulation, provides CVP measurement and serves as a port for temporary hemodialysis also, administration of drugs and even cardiac pacing. And this pulmonary artery catheter placement transvenous is mostly done in cardiac cath lab and in cardiac. So that is also done through that. Commonly right IJV is preferred. Okay. Uh, uh, that's most common as I said, and then it is the subclavian femoral or antecubital vein approach. Multilumen lines are inserted. You have single lumen, you have 2 lumens, 3 lumens, 4 lumens, different gate, different sizes are also available. Okay, so usually is what the Seldinger technique. You pass a needle, you pass a guide wire, remove the needle, dilate because that needle is thin, your catheter is thick. So you dilate, then you remove the dilator out, the catheter, the guide wire remains inside, and over that you insert that. You should not forget to remove the guide wire out. Otherwise, it's another procedure. Okay, guide wire tip has to be, otherwise it will be problematic. Okay. So how long can you keep the catheter? So depending on the duration and the type of catheter and what's the use you do it. So short term or temporary can be placed up to 6 weeks before either exchanging or replacing. Now all that depends in different scenarios. What type of ICU setup, what nursing care is there, many things that we usually don't keep for 6 weeks and all in our setup. Okay, because ours is a hot climate. That sepsis and all that are not very well practiced by doctors, nurses, everybody. So we usually don't keep for 6 weeks and all. If it is there, and that is why a transparent dressing is put up so that you see what anything rash or any redness or anything like that is developing. So, and of course the material which are there, they are antibiotic coated. Lot of things are available. So depending on that, we decide to give. And long-term catheters are also available and they are used. So they are used for total parenteral nutrition, for giving antibiotics and other issues may develop. In the triple lumen, one must remember there are 3 lumens, common ones which we have in our setup. Distal is the 18 gauge brown port, the most proximal to RF. It is used for general access and administration of blood products. The middle port is the blue one. Usually you connect a CVP. Usually you see through that. Okay. And if you are transducing, attaching a transducer, those who have seen that, then direct you get in the monitor the CVP reading and the transducer. Okay. And the proximal is the white one, which is also usually 18 gauge for blood samples, nutrition, etc. So that depends on what setup you are doing and for what you have passed it. Now, what are the contraindications? Absolute would be if there is SVC syndrome, pneumothorax, hemothorax on the opposite side. Because in case this side also pneumothorax or hemothorax develops, then it is problematic. So ideally, after every IJV, you are supposed to do an X-ray and all, but that's not practically thing. If you are suspecting or anything, you can do it. Plus, that setup has to be there. The patient is intubated on ventilator and all. X-ray के लिए किधर और लेके नहीं जाएगी. Means that's impractical. Okay. So relative will be coagulopathies. That's very important. That is the another one reason why you would prefer IJV. You can at least compress if the carotid subclavian something. There is nothing to compress here. It's down. So you can't compress. Okay. So that's one another important scientific reason why you prefer a IJV. Okay. So if there are coagulopathies, you have to be very careful. That's why now that ultrasound is under vision, you are doing everything. It's not with coagulopathy you will not pass. There are a lot of patients with coagulopathy who need central line. Okay, so we used to do that when ultrasound was not available. I have not seen ultrasound in my residency or for I don't know decades. So ultrasound has come now last means just prior to COVID, 1 or 2 years ago, all theaters received ultrasound machine. Otherwise, we used to pass, 1 or 2 people had it, 1 or 2 OTs had it. Otherwise, it was all landmark technique only. So it's not that it's not, but it's said if it's available, try to use that, especially in patients which are having this relative contraindications like coagulopathy. So you don't accidentally puncture the carotid artery. Then some carotid disease is there, thyromegaly, previous neck surgery, or they are going to operate on the left side and they still want a central line on this side. So you have to be careful while you are introducing. So this I already covered. Right side, why it is preferred straight, lung is lower and thoracic duct is there only on the left side. Okay, so this is the reason why you prefer the right side. Now there are many approaches which are there: central approach, anterior approach, posterior approach, supraclavicular. A lot of approaches are there. You select which approach which you are comfortable. So I'll teach you one which is most easy and most. It's not my approach or anything like that. So from the apex of the triangle, it's called the central approach. Apex of the triangle, two heads of sternocleidomastoid and clavicle. Okay, so apex of the triangle, let's say this is right side, patient's face is here, right, left, patient. Okay, this is the sternocleidomastoid, and if you are using landmark technique, you usually need extension of head. If ultrasound is there, you don't need this thing because it obliterates. Okay, so if you decide what you want to do, and accordingly you will put the extension of hand. So you put what is called as a shoulder. So two heads of sternocleidomastoid, clavicle is here, patient's nipple would be here, right side cut. So from you puncture from the apex of the triangle and go in the ipsilateral nipple direction. Okay, so you have to have a control because it's little longer needle. So have a control over the. See that you first puncture the skin, then take negative suction. Okay, syringe should have negative suction. Do not let that negative suction go. Otherwise, that blood will not come. You may not be able to get that thing. And go till you get a good backflow. Aspirate, and that control you have to have that the bevel is in the lumen, as I said earlier for peripheral also. If it is in the wall, you will still get, but your guide wire will not go effectively. Now, guide wire has markings. So 10 centimeter is the length of that needle. So 10 centimeter, it is anyway going to go smoothly. Okay. So beyond 10, it has to go smoothly. Then only it is gone in the lumen. So if the half bevel is in the wall, I mean the bevel of that is in the wall, that guide wire will not go. Okay. So till 10 तक it is go, everybody will say, madam, it is going properly, it is going properly. But वो 10 में तो जाने वाला है ना, उधर कुछ obstruction ही नहीं कुछ. Okay. So beyond 10 is when it comes out from the tip, there where it has to be in the lumen. Okay, so from apex of the triangle of the clavicular and sternal head of sternocleidomastoid, it is aimed caudally laterally towards ipsilateral nipple. Okay, complications, less incidence of pneumothorax hemorrhage. That is the best approach with landmark technique. Then there is anterior, then from medial border of medial head. This is what I prefer and this is what I teach in the OT. Okay. So then sometimes you don't get ultrasound is maybe नहीं हो रहा है कुछ machine not available, not working, ऐसा कुछ बहुत कुछ scenarios you may have. So such thing is there, then you may use the other approaches. So medial border of medial head 5 centimeter, you have to remember too many things. Okay. So I don't prefer all that. This for theory or for exam you can remember all these things. Okay. Then steps, as I said, you have to put a shoulder below it. So if it is in low conscious patient, then you will use local anesthesia. So you will give local because it's a big gauge needle, which will be there. Now when you give local, see that you don't, your local doesn't go in the blood vessel. Okay, otherwise you will have another complication. So you don't want that. So you have to be careful. So you give local and don't create a very big wheel that landmarks only disappear. Because landmark technique में you have to know the landmark, no? So don't create a big wheel with that local. नहीं तो you will create where उधर ही इतना बड़ा कुछ hematoma जैसा लगेगा. So don't do that. And you give proper liberal local. So when you take those stitches for fixation, then again you don't have to give local. Okay. So you give accordingly local, or you have to do it again later on, depending on how where it is getting fixed. Okay. So you give local. You again then do your standard. Technique, use your ipsilateral nipple direction, aspirate, and what otherwise you can do, going to give anesthesia to this patient, but you need a central line pre-induction for some cases or scenarios. You can take one stitch and induce the patient and then take the remaining stitches. But see that in that way it doesn't come out and all that. You have all those things, patient gets shifted down and the whole IJVs come out. So you have and patient with difficulty, if you have had a coagulopathy, then all that problem. So you have to be very careful when you do all these things. Okay, you should focus what is happening. See that the wire or that extension is not tucked inside and something has not gone. So you have to be proper. All your wires and all should be loose, so that if patient is taken, or you should see that servants, they tell you when they are taking, or surgeons, whoever is taking, and very gradually it should go from this to end to that, and suddenly the patient should not be taken down. Okay. So this is, I think, more or less you get it. And prior to the needle which is there in the set, usually some sets provide with a marker needle, some sets do not provide. So that then usually one black color needle we use, and their black also comes little long and one short one. Two types are there in our setup. So usually take a longer one. So first you do that's called as a marker needle, because it's a thinner needle. So in this, if you puncture carotid, then a big hole and hematoma will be there. That it will be relatively less. So you take your marker needle, get your blood flow, disconnect the syringe, then take your needle which is provided in the set, again pass that. Now that needle, either there are many ways in which you can pass the catheter depending on the set. So they have what usually we have is a side arm is there. So through that you don't have to disconnect the syringe, correct? So you can pass. Then some which doesn't have a side, so you have to disconnect the syringe. Now in some you don't have to disconnect syringe, but only one arm, but there is a lumen inside. So guide that syringe and needle is there in your this thing, and through that whole lumen you can pass the guide wire. Okay, so that is all different companies have the different. Now once you get that, your hand has to be very stable. See that you don't move around and this that वो needle पूरा हिल गया इधर से उधर हो गया, then again there is problem. Okay, then you again that needle may come out, it may be in the wall, it may not be in the wall, or you will pierce through and go outside the wall also. Okay, so you have your hand has to become very stable, in which now if you are right handed, then left hand, so you will hold it and take your guide wire and pass. Now if you're left handed, then obviously you will try to do it with the other hand, or if you are both hands, then you can do whatever is convenient to you. So some resident we find it difficult to teach if we are right handed and they are left handed. We find it difficult to teach. Then sometimes they say no, we can work with both hands. So see, if I don't know anybody is left handed here, first year, one person, so little difficult when you are going to learn. Okay. And if you have that marker needle and that other needle, usually you don't need to make a cut, because cut creates a scar. Okay, when you pass the dilator. So if you take two needles next to each other, then usually you don't need. Otherwise you may have to sometimes, if a bigger gauge is passed, you may have to make a little cut on the skin for the bigger dilator to go through. Okay, so this is the two heads which are shown, the triangle of the thing, and that's the clavicle. Okay, that concept is clear, triangle. Okay, sometimes if it is not visible, even by extension and all, it is not visible, you can palpate. The unfortunate thing is now, because of ultrasound, your brachial plexus block and all, everything is through ultrasound. We used to do with landmarks, so we knew where is what groove. Now because of this ultrasound which has come, y'all are not, so you just remember your neck anatomy and see what is the first groove and second groove and all, where your brachial plexus. So for that, this also helps. So many times if the patients are little obese, it's not uncommon to have obesity now. So you don't have good classic landmarks. So you can go by palpation, feel the sternal notch, feel the first groove, feel the apex of the triangle, and then go. Okay. So what are the components, that numbering and all? I'll just show you all. Is there wo arrow are right here? I'll show from here. So this is the catheter one. Notice there is two. This is the guide wire. Okay. Now guide wire, this has a J tip. So you should withdraw till the uska jo case is there. Withdraw it. Otherwise this flabby thing will not go. Then this is the needle with the side up. Okay. There will be usually a blocker there. So you put a guide wire through here and your syringe is here. 4 is, this is the dilator, this is a blade for cutting suture, and in case you have to make a nick on the skin, this is the syringe, this is the case of that guide wire, this is the fixator. Okay, so as I said, you don't insert the full thing. So the entry point from where the skin and the thing comes out means it's gone inside, right, under the skin. So where that entry point is there, let's say this is the skin, here from here the cannula is coming out, so here is where that fixator will be there. So you will have to fix there also, and you may have to fix here also. Okay. So let's say you have inserted somewhere here is still 12-13 centimeter. Okay. So here will be your, this will be coming here also. Okay, and then you suture up. So you, and there is a groove here. So usually you do 5-point suturing. Okay, and put a transparent dressing. Any number is meter. Some have this sponge like thing, so that helps it sticking. Some have some what is that, we had that round thing, bio patch is available for whatever is available, or the dressing has some coating of it in that. So whatever is available you can use. Okay, so these are all, and see that you, after insertion, you see that backflow is there in all the 3 lumens. No blood tinge should be there. Blood is a big source of infection. Okay, central line catheter insertion is not a small thing. Patients will be with this at least for 5-6 days. So everything else goes good, and if there's an infection ho gaya, so it is all fuss. Okay, so you must do it with all aseptic precautions, and no blood tinge fluid should be there. I always shout in my OT, I don't want all ports, I want clear, because that's where no air should go, obviously, because you're directly, it is going in the circulation, central circulation. So tip should lie above the RA in SVC. So SVC RA junction ka just upper it should lie. Okay, so there are ways in which you can even detect that also. So I am not covering that, that's too much for you all today. Okay, so you should have this, all your ports should be clear, aspirate, clear the fluid, and connect your pint or drug or antibiotic or drug, whatever you want to give. Okay, so these are again the steps. So you can see there are many people who teach that you palpate the carotid and this. I personally don't like that. Why? Because IJV, this is my logic. IJV and carotid is in one sheath, correct? Now if you palpate that carotid and displace that IJV भी displace होता है, बराबर? It's in one sheath. And what displacement, that landmark is all gone, because your landmark is without displacement. Okay, so you palpate the 2 heads of sternocleidomastoid, see where it is, spread your fingers and puncture. Okay, so hence I don't prefer, otherwise many of you all know palpate karke aisa waisa, those different approaches में that different thing is there. So this you do learn this properly, most of the time you get success in your IJV. Okay, so this is how you can see how it is done. Okay, and then the guide wire is introduced. That's a guide wire which is the dilator, and that's the fixation. So on the left side, as I said, if sometimes you need surgeries on this side, right side you're not getting, or some thrombus is there, something different reasons may be there. If you need, this technique and all remains the same, only thing you have to be little careful. Now subclavian, it's usually used in trauma patients and cervical spine is immobilized. It can be used in long term, chemotherapy, TPN, etc. Advantages is that here it is, no, it is as something is hanging, no, for the patient. IJV है तो ये थोड़ा comfortable है. But you have to see what, that is why if in wards and all that, many times surgeons and all prefer this. But in the OT, where patient is not going to be roaming around immediately, 3-4 days, so he will be little immobile and things like that. So you can fix it up and it can help. Even if you have seen dialysis patients, they have that jocath and all, that is also in the IJV only, because that is more better than the clavian. So subclavian we will teach you also, 2/3, 1/3 is the landmark of the clavicle, and you go towards the sternal notch. Same, I mean right side and going towards the sternal notch. You can see that photograph there. Okay. So step is again same. If it is under low, patient is conscious, then you will introduce local and then you will insert it. The only thing here, there is chances, more high chances of pneumothorax. Okay. So, and if there is hematoma, puncture or something, means blood vessel is, arteries got punctured or anything, then there is nothing to compress. So you have to be little careful. Okay. So you will not too many attempts as he written, is not punctured in second, third. You don't do too many attempts. Okay. Now ultrasound candidate is now considered the gold standard, because you see it and you do it. So less chances of complication are there, but there will be many scenarios, many times when ultrasound is not available. Not only here, even later on. Ultrasound is fully, every center will not have ultrasound. There are a lot of other, there's legal issues also which are there. You can't move from here to there and things like that is there. Of the PNDT Act which is there. So those issues are there. So hence ultrasound you have to have now in every area, because you can't move the machine. Okay, so those issues may be there. You may be still in emergency and all. Everywhere you will not have a central line. So you must know the landmark technique also. Okay. So ultrasound is you put the probe. You should know how to hold the probe. Your left hand has to become stable. If you, I'm talking because I am right-handed. So your right hand is in the probe has to be properly placed, and in plane or plane that Anil will teach you all how to hold that and where you have to go, how much and all. Okay. And once you get it under vision, so you should be able to see the carotid artery and the IJV, and you see your line of puncture and see that you are not going through the carotid artery or something like that. So your bring the probe up or down so that they are lateral to each other. Okay, because if you remember the anatomy, the carotid will first it is ahead, then goes beyond and all that. So you have to have it where they both in the your screen is lateral, then only know if it is upar niche to wo puncture hoega, correct. So, and then if you want to see Doppler and all that, I'm not covering all those things. It's not needed. So, short axis view, long axis view that Anil will, I think, take in the station. Will not waste too much time on all this. Needle tip. You should see the tip. When if you are using ultrasound, then the tip has to be visible where you are going. Don't go blindly. Then there is no problem because you are not having extension and the direction and all is different. You will puncture surely the carotid if you are not looking at the screen and going. Okay. Then the long axis view and all. I think that all we will take in the transducer, the ultrasound station. Okay. Dark venous blood conformation is there and should lie parallel to the vessel also in the SVC. Now, other complication is, as I said, the blood is a big source, so that uh, infection is a very common complication that can occur. So you have to use all aseptic precautions, put a proper dressing. You should be washing up and all those things. That's all basic. Matlab, you must have seen all that. So incidence of infection is not rare. It's not. I will not say every patient will have, but it's not that you will not see it. So you have to be very careful. Your dressing has to be proper. No blood pinched. Your ports should be all clear. All blockers should be put. Okay, that's all is very. And you have to learn all this at this level only, because once you become 2 3 months now, you learn all wrong things. Those habits never develop. Okay, so I take a syringe in my hand. I have that habit because that's how I was trained. You remove your blocker, it remains in my hand, and put the syringe immediately. The blocker goes, whether it is peripheral line, central line, or anything. Other habit I have is I always aspirate. That port in the three-way will always have a bubble of air, whether it is peripheral line or central line. Some fluid is connected, so always aspirate. Of course, if something adrenaline or कुछ चल रहा है, तो don't aspirate and कुछ flush मत कर डालो, कुछ और हो जाएगा. What I'm trying to say is, you turn the three-way, don't immediately inject, aspirate slowly, so that you will always see one bubble of air will come, because that port will have an air. So aspirate and then inject. I always have a habit of aspirating, because that is how I was trained. So my those habits still remain. So because you all are still just new, don't और ब्लॉकर नहीं लगाने का कुछ नहीं होता है. मैंने तो अभी 100 IJVs I have seen, no patient has developed, but one patient to develop, no, it is disaster. Okay. Then this all hematoma and all pneumothorax I have already spoken. Arrhythmias can occur if your guide wire is when you're inserting. No, that's actually one sign. Actually, you're stimulating. So, thoda guide wire you can withdraw. You don't want some arrhythmias to develop and some complications to occur. Because initial phase, you will be little slow to pass. No, when we have passed many, you are little fast. So you will take little time to pick up these. That you will think, abhi next step kya hai and all that. So it will take time. So you don't want that arrhythmia thing too, because your guide wire goes way inside. You can have stimulation of the myocardium and you can have arrhythmias. Okay. This I've covered, steps we have covered. So this is what the landmark which I am saying, injection point, and this is how the ultrasound will be using. This too much detail I think we can avoid. Now this infection, as I said, central and associated bloodstream infection, CLAPSI, which is called. Now this company has this thing. I'm nothing in that company, share with कुछ पैसा वैसा मेरे को मिल नहीं रहा है. But because I'm just speaking about this, so their central catheter has some coating. So I'll talk about that, and that helps in, it's claimed in the studies and all that helps in uh, minimizing or prevention of infection. Okay. Uh, So central and associated bloodstream infection and thrombosis there, because what you can see this redness which is there. That's why a dressing is always to be a transparent dressing. Ideally even for peripheral line. But itna what transparent dressing, the tegadam is a costly thing. So we may not have so many. See, we have to make shift and do many things. So that's why we put that Dynaplast which you all are called as biscuit. Okay, with the cut and all that. So ideally you should have transparent one. So if anything erythema or anything is developing, and that's the, see, you can see the thrombus, because you want to insert IJV, many times you will have patients who are having IJV thrombus. That you can't pass because you may embolize that thrombus while inserting. Okay, so this is about many cases are there and all those things are there. And in COVID also, they found that many hospital-acquired infections have occurred because of this, and we are all aware of drug-resistant bacteria which are there. There's a big thing now. Okay, so you have to be careful. Hence, I'm just stressing, please use aseptic precautions, put the blockers, see that blood tinged things are not there on the port, see your area is not very messy. Otherwise, you will, that blood will come, वो syringe उस पे डालोगे, that catheter which is going to go in the patient only is all blood tinged. उसको before inserting only you will make it blood tinged. So see that your trolley is well arranged, keep your unsterile and use things at one corner. Set up your trolley problem. Learn all these habits properly now. It doesn't take time. Whether you set it up now or you make it messy, the time is same only. So it's better to have it done properly. Okay, these are other studies which are there about ICU and all that. Now this is what that concept is there, is there are different stages till you get their infection, right? First contamination, then colonization, local infection, then it spreads and then it becomes into system. So what this people, what is that BIP, what is that? That is bacterial infection protection, that is there. So over here only it stops their infection. So if this step only you are blocking, the further things don't happen. Now, how is that? They have that novel technology. What is there? So that is called as a galvanic effect. Again, I'm repeating. I have nothing in that company, or I'm promoting this, or nothing like that. It's just they have brought this mannequin, so I'm speaking about it. So when it comes in contact with the fluids, the metals are there. You can see that gold, silver, palladium is there in that coating is there. So that metals create a galvanic effect, and electropotentials which are create a microcurrent. Okay, so hence that infection or bacteria which is coming, it goes away. Okay, hence it prevents the addition. So microbes don't get stuck to it, and hence that's the concept. And it's a non-releasing mechanism. Okay, so now